Hi. Cell death is a consequence of irreversible cell injury. The hallmark of cell death is loss of nucleus, which occurs via nuclear condensation, also known as pyknosis, nuclear fragmentation, also known as karyorrhexis, and nuclear dissolution, also known as karyolysis. The two mechanisms of cell death are necrosis and apoptosis. Let's start with necrosis. So necrosis occurs with the death of large group of cells followed by acute inflammation. Necrosis is caused by factors external to the cell or tissue such as infection, toxins, or trauma, which result in the unregulated digestion of cellular components. So it is always due to some underlying pathologic process. It is never physiologic. Necrosis is divided into several types based on the gross features. The first type of necrosis we are going to look at is coagulative necrosis. So in coagulative necrosis, the tissue remains firm and the cell shape and organ structure are preserved due to coagulation of proteins. However, the nucleus disappears. This type of necrosis is characteristic of ischemic infarction of any organ except the brain. Now, the brain is made up of neurons. Therefore, it cannot undergo coagulative necrosis. It undergoes liquefactive necrosis, which we shall look at shortly. The area of infarcted tissue is often pale and wedge-shaped, pointing to the focus of vascular occlusion. Red infarction arises if blood re-enters a loosely organized tissue. A classic example is testicular infarction. Organs that undergo red infarction usually have a dual blood supply, like in the case of the testicles and the lungs. Now let's look at liquefactive necrosis. In liquefactive necrosis, the tissue becomes liquefied. Now the enzymatic lysis or breakdown of cells and proteins is what results in liquefaction. A classic example of liquefactive necrosis is brain infarction. So in brain infarction, proteolytic enzymes from the microglia cells liquefy the brain. Another example is abscess formation. So in abscess formation, proteolytic enzymes from neutrophils liquefy tissue. And another example is in the case of pancreatitis, where proteolytic enzymes from the pancreas liquefy the parenchyma of the pancreas. Now the third type of necrosis we are looking at is gangrenous necrosis. So this can be described as coagulative necrosis that resembles mummified tissue, also known as dry gangrene. Gangrenous necrosis is very characteristic of ischemic or ischemia of the colon as a result of embolism of arterial supply to the colon. Now it is also seen in strangulated hernia, into succession, as well as volvulus. So gangrenous necrosis also affects the limbs, especially the foot. And if the dead tissue in gangrenous necrosis is superimposed with an infection, then liquefactive necrosis ensues. And in that case, the dry gangrene becomes a wet gangrene. Now, let's look at caseous necrosis. So in caseous necrosis, the tissue maintains a cheese-like appearance. The dead tissue appears as a soft and white proteinaceous dead cell mass. Caseous necrosis is very characteristic of granulomatous inflammation due to tuberculous infection, as in the case of tuberculosis, or even in fungal infection. It can be described as a combination of coagulative and liquefactive necrosis. This is a schematic representation of gaseous necrosis, and we see that the necrosis or the necrotic core is surrounded by Langerhans giant cell as well as epithelial cells, lymphocytes, and fibroblasts. The next type of necrosis is fat necrosis. So in fat necrosis, the adipose tissue, for example in the breast, develops a chalky white appearance due to deposition of calcium. Now this can be seen in trauma to the breast as well as in pancreatitis mediated damage of the peripancreatic fat. Now this is what actually happens. So when there is trauma to the breast, fatty acid is released. In pancreatitis, lipase is released. Now fatty acids from the breast and lipase from the pancreas join with calcium via a process called saponification. So saponification is an example of dystrophic calcification in which calcium deposits on the dead tissues. In dystrophic calcification, the necrotic tissue represents a breeding place for calcification in the setting of normal serum calcium and phosphate. On the other hand, metastatic calcification occurs when high serum calcium or phosphate levels lead to calcium deposition in normal tissues. A good example of metastatic calcification is in the case of hyperparathyroidism leading to nephrocalcinosis. So in this case, there is deposition of calcium in the renal parenchyma due to hyperparathyroidism. Now the last type of necrosis we are looking at is fibrinoid necrosis. Fibrinoid necrosis usually occurs as a result of damage to wall of the blood vessels. It involves leakage of proteins including fibrin into the vessel wall. The necrotic core in this case is usually surrounded by foam cells. Now fibrinoid necrosis is characteristic of malignant hypertension and vasculitis. The second mechanism of cell death we are looking at is apoptosis. So apoptosis is defined as an energy-dependent, genetically programmed cell death involving single cells or a small group of cells. Examples include endometrial shedding during menstrual cycle. So normally the endometrium of the uterus grows with exposure to estrogen and sheds with the exposure to progesterone in a normal menstrual cycle. This is a necessary genetically programmed process of the endometrial cell death that occurs with exposure to progesterone and the expenditure of ATP or energy. Another example of programmed cell death is removal of cells during embryogenesis. So for example, in the formation of fingers during embryogenesis, extra cells or tissue has to be removed from in between the fingers in order to prevent the formation of webbed digits in the fetus. Now let's look at the morphology of apoptosis. So this begins with the shrinkage of the dying cells and condensation of chromatins due to a rapid proteolysis of nuclear matrix proteins. Now this is followed by formation of membrane blebs and the disintegration of the organelles. There is collapse of nucleus and the organelles leading to formation of apoptotic bodies. Now these apoptotic bodies end up being eaten up by macrophages. In other words, there is phagocytosis of the apoptotic bodies by macrophages. An important fact to note is that unlike necrosis, apoptosis is not followed by inflammation. Now, apoptosis is mediated by caspases that activate protease and endonuclease. Protease breaks down the cytoskeleton, whereas endonuclease breaks down DNA. So caspases are activated by multiple pathways, and here we are going to look at mainly two pathways, which is the intrinsic pathway and the extrinsic pathway. So the intrinsic pathway, also known as the mitochondrial pathway, is activated by intrinsic lethal stimuli such as DNA damage, endoplasmic reticulum stress, hypoxia, and metabolic stress. Now this leads to inactivation of BCL2. Now BCL2 is an anti-apoptotic protein, so it is supposed to prevent activation of the pro-apoptotic proteins BAX and BAC, or BAX and BAK. So without BCL2, the BAC and BACs, which are pro-apoptotic proteins, will form pores in the mitochondrial membrane, and this will lead to release of apoptogenic proteins like cytochrome C. Now, cytochrome C and other proteins released from the mitochondria will lead to activation of caspase 9 and caspase 3, resulting in the apoptotic program. Now, the next pathway for activation of apoptosis is the extrinsic pathway, also known as the receptor ligand pathway. And in this case, Fas ligand binds to Fas, death receptor, or FAS death receptor, also known as the CD95, on the target cell. Now, this leads to activation of caspase 8 and caspase 10. Now, activation of caspase 8 and caspase 10 also causes the activation of caspase 3 and 7, and that leads to the stimulation of the apoptotic program. I hope you enjoyed the video. Please like this video and subscribe to the channel. More videos coming up. See you in the next one.